Hello and welcome to the second lecture of medicine lecture series. And in the neurology unit, today we will talk about transient ischemic attack, that is TIA, very important topic from neurology. And you can subscribe this channel for more such videos. So we will go through it fastly so that you can revise TIA in short period of time. So transient ischemic attack, what is TIA? Definitions. There are two definitions. First is the classical old definition, and the second is modern, that is tissue-based definition. So TIA, or what older definition says, it says the transient episode of neurological dysfunction, focal neurological dysfunction, which is caused by cerebral ischemia, but complete resolution within 24 hours and no infarction. So these were the important words included or terminologies included in definition of TIA. The older version, that is, it should be transient, it should be focal neurological dysfunction, cerebral ischemia, but complete resolution within 24 hours. So the time limit was 24 hours and no infarction should be there. And the modern tissue-based definition, it says that TIA is a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. So the most important line which they have added here is without any infarction, and they have removed the time duration. So time duration has been removed from the newer tissue-based definition. So this is basically tissue-based versus time-based. So the newer latest concept is tissue-based. There is no infarction, then it is TIA. If infarction is there in diffusion imaging, then it is stroke. Now, why TIA is a medical emergency? Because what is TIA? TIA is basically a warning stroke and 10 to 15% risk of a stroke within 90 days of TIA. A person who suffered from TIA, they have risk of 10 to 15% in the coming 3 months. And highest risk is within first 48 hours. So it is important to admit TIA patients for observations because they can develop a stroke within the next 48 hours. So TIA is not a minor stroke, it is a major predictor of a disabling stroke. So this is a line to remember. TIA is not a minor stroke, but it is a major predictor of a disabling stroke. Now, in short, about pathophysiology of TIA mechanism is the same like stroke. So embolic phenomena can be there, the cardioembolic, that is atrial fibrillation or LV thrombus, artery to artery embolism, that is carotid plaque. The second mechanism can be thrombotic, that is large arterial atherosclerosis or any intracranial stenosis. Third, hemodynamic, that is severe carotid stenosis plus hypotension. And fourth, small vessel disease, this is lacunar TIA, it can be pure motor or sensory. What is the important concept? Ischemia reverses before neuronal death in TIA, and there is no permanent infarction in the diffusion imaging in MRI sequences. So, ischemia but no neuronal death and no permanent infarction. Now, clinical features of TIA. If we look at the general characteristics, it is sudden in onset, focal neurological deficit is there, and negative symptoms. It is loss of function. It is important. No positive symptoms, but negative symptoms are more common in TIA. And what are the common TIA syndromes? They are basically you are into anterior circulation TIA and posterior circulation TIA. Now, anterior circulation TIA, patient may present with hemiparesis or hemisensory loss, or aphasia, or ameurasis furious, that is retinal ischemia, or the blurring of vision or decreased vision. So these are the characteristics of anterior circulation TIA. In posterior circulation TIA, patient may present with vertigo, diplopia, dysarthria, ataxia, bilateral visual loss. So these are the features which are seen in posterior circulation TIA. So positive, if a patient presents with positive symptoms, that is jerking, movement of limbs or tingling or flashing lights, then we should think about migraine or seizure, but not TIA because TIA usually have negative symptoms and not the positive ones. Okay, so this is again important discriminatory point. So TIA usually have negative symptoms, that is loss of function. Now, TIA versus stroke versus the TIA mimics. So TIA and stroke, what are the features? Duration of TIA is minutes to hours, and it is 24 hours. Latest definition excluded the duration. In MRI diffusion imaging, TIA is normal, while stroke has positive, that is acute infarct If they are in stroke, no infarction, ear infarct is there. Deficit is fully reversible in case of TIA. As the name itself suggests, it's transient, but in stroke, it is persistent. So common TIA mimics, what are the common TIA mimics? It is very important in routine clinical practice. Migraine with aura, especially familial hemiplegic migraine, may present like hemiparesis and it may present, mimic TIA or stroke. And focal seizures, hypoglycemia may present with weakness and it has mimic TIA and syncopal attacks and any functional neurological disorder. These patients can mimic TIA-like symptoms. So these are the common TIA mimics: migraine aura, focal seizures, hypoglycemia, syncope, and functional neurological disorders. Now coming on to the diagnostic evaluation, what are the important diagnostic evaluation? Neuroimaging is the most important one. It should be done urgently. MRI brain with diffusion weight imaging is the gold standard for TIA, and CT brain can be done, but it only exclude beat, but it do not confirm the presence of acute infarct. So up to 30 to 40% clinically diagnosed TIA show diffusion lesions, that is acute, but actually a minor stroke, which resolves after a certain period of time, but MRI shows infarction, that is tissue death. Second, vascular imaging, carotid Doppler should be done to rule out thrombosis or stenosis of carotid arteries, CT angiography or MR angiography to look for more than 50% carotid stenosis or intracranial atherosclerosis for intervention purposes like stenting and other things. So, this is vascular imaging. Now, third is cardiac evaluation, which is very important for cardioembolic stroke. Cardiac evaluation for cardioembolic. If you are suspecting embolic stroke from cardiac origin, then cardiac evaluation is must in each patient of stroke or TIA. ECG should be done to rule out atrial fibrillation, echocardiography for any valvular heart disease or PFOs, and Holter monitoring for paroxysmal AF, which is not captured in routine ECG. So these are the cardiac evaluation. Now laboratory test, blood glucose very important. RVS should be checked in a patient in EMR emergency room because hypoglycemia mimics TIA or stroke. Lipid profile should be done to rule out as a risk factor for atherosclerosis. HbA1c for diabetes, CBC and electrolytes should be done. Now, how risk stratification is done? ABCD2 score, it is important to remember. Now, A stands for age more than 60 years and 1 point is given. B, BP if more than 140 by 90, then also one score. C, clinical, divided two parts, clinical weakness. Uh, Weakness for 2 points for weakness or hemiparesis, and again C, clinical is only speech difficulty, dysarthria or aphasia. Then one number is given, 1 point is given. Then D, duration if more than 60 minutes, then 2. If less than 60, that's 10 to 59 minutes, then 1. And if diabetes is seen, then one score is given. So ABCD2 scoring: A stands for age, B for BP, C for clinical findings, that is divided into two, weakness and speech, and D, first D for duration, duration again divided into less than 60 per minute and more than 60 per minute, and diabetes mellitus. So overall the score is 1, 2, 3, 4, 5, 6, 7, 8, and 9. So, but the total maximum score can be 7 only. So for 0 to 3, low risk of stroke, 4 to 5, moderate risk of stroke, and 6 to 7, high risk of stroke. Okay. So ABCD2 score is important in risk stratification. Now, management of TIA, antiplatelet therapy is the mainstay of treatment. Aspirin is given. Then we can shift patient to dual antiplatelet therapy minimum for 21 days, and we can also go up to 90 days, but minimal 21 days of dual antiplatelet, that is aspirin and clopidogrel, should be given, especially for high risk TIA with more ABCD2 score. So, evidence for this antiplatelet therapy in TIA, it is given in chance trials and point trials. So remember the name of these trials. Now, other thing is anticoagulant. If cardioembolic source is suspected like atrial fibrillation, then uh, these direct oral anticoagulants or novel oral anticoagulants or warfarin can be used. If valvular atrial fibrillation, then usually warfarin or acetone is preferred. If non-valvular, then we can go with dabigatran, apixaban, or rivaroxaban. So do not use dual antiplatelet in AF-related TIA. What we should use? Anticoagulant. And what are the common DOACs which we use nowadays? Either rivaroxaban in dose of 10 mg BD, this is therapeutic dose, or apixaban 5 mg BD, okay, or dabigatran can also be used. Dabigatran in the dose of 110 to 150 mg BD. So these are the commonly used anticoagulants. Now statins, the role of statins, high intensity statins should be given, rosuvastatin or atorvastatin, and target LDL. This is again important MCQ question as well as Viva question. What should be the target LDL after TIA? It should be less than 70. And blood pressure control, gradual reduction should be done, not rapid reduction, and avoid acute hypotension. So last point, next point, carotid intervention. Symptomatic carotid stenosis is more than 70%, then stenting is done, or carotid endarterectomy is also preferred. Stenting is done in selected cases. Prognosis of TIA, early stroke risk 5% at 2 days, 10 to 15% at 90 days. So highest risk in first 48 hours, and risk is highest with if patient is having diffusion positivity, that is already patient has developed acute infarct or any large artery disease or occlusion, and patient with atrial fibrillation. So this was in short about TIA. Thank you for your patience listening. You can subscribe this channel for more videos on uh, medicine lecture series, which is mainly Harrison based. Thank you very much.